Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Hello and welcome back to the Sit and Stay podcast brought to you by RipsyTech. I am RipsyTech's product manager, Parker Anderson, as always, joined by founder and CEO, Tom Tarshis. How you doing, Tom?
I'm good, Parker.
That's excellent. Excellent. Before we dive into today's episode, which I think ought to be pretty interesting, just some quick updates. We started a course called RipsyTech's How to Start a Private Practice course. It's all the rage. You got to go check it out if you're listening. If you've ever wanted to start a private practice, you can go find it at ripsytech.com/practice. It's a free resource created by Tom, actually, and it takes you through all the steps of starting a practice. So go check that out if you're interested. All right, Tom, what did you... I heard through the grapevine that you had some thoughts and feelings you wanted to get off your chest about a particular element of your job in this industry. I don't know. I wonder what that could be. Take it away. What did you want to talk about?
Yeah, and well, Parker, I think it's fair to say that you and Ryan Myers also contributed to the private practice course modules, and I wouldn't say it was just myself. That feels wrong.
Oh, thank you. I appreciate that. I just only meant to call to the fact that you star in the videos. So if people are interested in seeing more of your face, that they should go check out those RipsyTech How to Start a Private Practice course videos.
Fair enough. Well, yeah. And Parker, here's my beverage to help prepare for this podcast.
Oh, it's getting serious. We got gamer fuel in the building. Mountain Dew. Okay.
When you go through periods where you have a lot of, maybe what can be seen as wins, and other periods where there's a lot of frustrations, and this is just one of these periods where, really since the beginning of the year, but even within the past couple weeks, there's a lot of very frustrating and new things going on with insurance companies' treatment. Shocker, insurance companies' treatment of mental health providers, treatment of patients, and what you have to do to fight to provide good care and fight for your patients. And I think that, there's solace. We probably need to set up the mental health provider and accept insurance support group. That would probably be therapeutic to many people. Or just, get a Facebook insurance rant group. But there's just been several things so noteworthy that in our quest to actually try to help providers take insurance and deal with these headaches, because it's better for the patients. When this is part of our mission and new things happen to make it harder and harder, really gets me fired up and in fight mode. And so it will be therapeutic to discuss some of these ridiculous things that are going on, and then also good to give a heads up to people about some of these actions, and somehow push and work together to challenge and fight, because every single new restriction or hassle or headache that happens, it's another provider who takes insurance is going to say, screw this. There's enough demand, and I'm trying to do the right thing and taking this extra burden, but at some point you've just got to be like, I can't. At some point you just give up. I never will. Well, when I die, but
All right, I'm hanging on by a thread. Don't bury the lead too hard. What is that? I need to know. What are these changes, Tom?
Yeah, so let me talk about, well, let me start with the most recent thing that maybe like tipped me over the edge to like that's it. We got to do a podcast over all this stuff. So,
Okay.
and I won't name this insurer, but I'm thinking of naming others. But
Spicy.
we'll see. But this is a very large national insurer, and I just received this. You get lots of these notices all the time in the mail, and you could think it's junk mail, but usually I try to open and glance at it. And this was a good one to open and glance at because they're like, hey, and of course it's, in order to support quality care for our members and submission of accurate claims, that starting June 1st, there's going to be a new payment policy for
Okay.
prescribers with this insurance company. And Parker, you may know from repeated podcast episodes or the private practice course that if you're a prescriber seeing a mental health patient, the correct billing is to bill E&M by complexity, and then to do what? Use the
Add-on codes.
So Parker, you've got it right. Use the psychotherapy add-on codes when appropriate, and unless you're doing 15-minute visits, you definitely are meeting thresholds, because that is the world we work in, where you tend to ask people about how they're doing and give their therapy advice, and that's how the system was designed for reimbursement through American Medical Association and American Psychiatric Association, and working with Medicare. But this reads that this insurer would now deny psychotherapy add-on codes when the clinical documentation does not clearly support both the E&M service and the psychotherapy service as distinct and separately identifiable components of the same encounter. Okay, so I've known that. And in fact, Parker, you probably know from our way we structure our notes, we have distinct sections to help people prove that point. So okay, that's okay. Like, but then there are 7 bullet points attached, and the first 3 are not a big deal. One of them is saying, you can't use prolonged E&M services when you use psychotherapy add-on, and that is correct. That there's this 99417 code that is for billing by time, so fine. You're not supposed to count the time spent on activities of the E&M service. That can't be counted. That's our medical decision-making complexity. So I'm not sure, are you supposed to like tap thinking about the patient now? Go. Okay, done thinking. And anyway, as we tell people, there is some time limit there where you're processing the information. So in our notes, it's document the therapy time separately from what that time component is for the other piece. No, not an issue. And then the ones though that are new are that they're requiring on billing claims that you add what's called a modifier code, which is what you're supposed to do to show that a service is needed. It's a separate billing thing to show that it could be performed on the same day with an E&M code, which is really just a nitpicky way to catch people off guard and deny a bunch of claims because you forgot to put this modifier code on your claims form. So this is why we have our own EHR. We can fix this with technology. We will automatically apply that modifier code, but many people will miss this. Here's the one that got me though, Parker. This bullet point: the medical record must support that both services are medically necessary. So
Okay.
my patient coming to me for therapy and medication management, you're telling me that every single time I see them, I have to add a sentence or more justifying why therapy is appropriate. Like, this is, if someone's coming for depression treatment, there is solid evidence-based guidelines, regardless of the age, that therapy is more effective than medicines for treating kids, and about equally effective or even more effective in adults. Yet somehow I need to say that my doing therapy is medically necessary. Every single note, it is too much, right? And so in California, there are some laws in place that you can't require mental health visits to have to document more than other medical divisions, right? So is
Okay.
this, or orthopedic surgery, you need to justify why this patient needed anesthesia, right? It's, what is the
Right.
gold standard care that you're supposed to provide? And it is, we already have to document how progress is going in therapy. We have to make it distinct. We have to put the type of therapy, which, okay, those are all sort of reasonable-ish. But now adding a new section like why therapy is medically necessary. Hey, bruh, that's like the gold standard of care. And it is just going too far. It's because it's the right thing to do, right? So you know, trying to put aside cynicism, sarcasm, and snarky responses to insurance companies, uh, you know, uh, I would want to actually put, hey, because we care about our patients. They try to say that they're doing this out of, quality of care for their patients. This is 100% the opposite. And it's to push prescribers and psychiatrists uh,
Out
away
of
from
performing
doing.
therapy.
Yes, and then, right, it is our job and our goal, and the Hippocratic Oath is to provide the best care possible, do no harm to your patients. And they're trying to say now, hey, doctors, no more, hey, no more therapy for you, right? You can prescribe meds. It is antithetical to everything we've done our entire life. And I have had it, Parker. I'm, I'm I'm going after this with everything I got.
Well, all right. In the interest of playing devil's advocate, not that I believe what I'm gonna advocate for. Okay. Is it possible that there are um what's the word? Bad actors as providers who are maybe providing therapy for unrelated illnesses? I don't know. Does that make sense? Is it ever
Uh,
bad to give therapy to somebody? Hmm.
yeah, I mean, I don't see if you can. I like the devil's advocate thing. Like, yeah, pretend you're
Yeah,
an
yeah, you're
insurance
welcome.
company executive in front of the board. We need to turn up those profits because they are only, we want double-digit billions. 6 billion's not enough. How can we word something that is being good for our patients to like?
I'm not advocating for that devil. Um, yeah, I mean, I guess, yeah, just is there any reason why somebody might be thinking like, oh, because like we need to know that this is medically necessary because people are just giving out therapy when I don't know, maybe patients don't know that they're receiving therapy and I don't know, maybe the patient got billed more than they expected to because therapy was provided and they only expected, I don't know, an ADHD medication refill. I'm not sure.
I mean, let's see if can we squeeze. The issue is, Parker, that we already know there's these, right, separation of documentation and like telling what you've done and sort of showing progress. So if there are um providers who've been, first of all, it is hard to imagine any scenario where you're just trying to defraud the insurance company through adding E&M codes when you see patients for therapy. Like it is hard
Right.
to imagine, right? Like the real defrauding is you see, 5 patients an hour and but then you're 100% providing bad care. And, so it is hard to imagine anything charitable. If there were people who were doing this therapy add-on code and their documentation was sort of like, sleep, appetite, medication, side effects, see you in 2 weeks, like that would be wrong, but they would lose the audit because they didn't document the psychotherapy type they were doing and where they're at. And so I just feel like what is this and the subjective nature of, can we throw a checkbox on our form saying check here if therapy was medically necessary? And
Right.
that's,
Is that enough?
yeah. And how do we help our users and colleagues deal with this ultimately ridiculous requirement?
Yeah.
Right. It is too much. So I'm going legislative avenues, and I think there are already protections in California, but right, other states are going to have to deal with this. But I was blown away by this one.
Okay. Well, I mean, what else you got? That's a heck of a one.
Yeah. So let me do this. Let me do this one, which this one has only happened to me once, but it did happen, and it happened fairly recently. But it's happening to some of our clients and some of our friends. That is why it's also been on my mind. So, Parker, for the mental health providers that don't accept insurance, it's
Mm-hmm.
still nice if you submit claims for your patients on their behalf.
Right.
And anyone can do this. You do the visit. You can hand your patients a super bill, which is what most cash practices do. But if you want to like differentiate yourself a little bit from a cash practice or do something that helps your patient a little, you can actually go ahead and submit the claim electronically on behalf of your patients with a little legwork. And the advantages of that are, people, even though it's easier to submit super bills for reimbursement now, most people don't do it, so they don't get money back that they're entitled to. And if they do have a plan that pays well, right, a check could come right to your office, and then you actually don't have to charge the patient as much once you know what you're going to get from the insurance companies. When this happens, and the way that the explanation of benefits or what the patient gets from the insurance company will show, hey, I saw out of network provider Dr. Anderson. He charged $200 for an hour of therapy. The insurance paid $75, so patient owes $125. So it would show that you were out of network. They did pay some, and that the patient owes the rest.
Right. Okay.
If you were in network, Parker and Dr. Anderson, and your usual charge is $200, there will be the discount rate. Okay, you let the insurance company pay you $150, so it will show that discounted rate. And then if the patient copay is $20, okay, insurance paid $130, you owe $20. That's what
Okay.
in network. When you see any doctor that has your copay, that's what that looks like.
Right.
So what happened in our clinic was we had a patient with their out of network insurance. We submitted the billing for them. They sent us money. Let's throw some numbers in to make it easier to visualize.
Okay.
Say we charged $500 for out of network, and then they paid $200, and so they sent us $200. But then the explanation of benefits to the patient said, they charged $500. We're only paying them, we only think they're worth $220. So we're denying the rest of the charges, and your copay amount is $20. So they're making the explanation of benefits look like it was an in-network visit when we do not accept this insurance. Let me pause there.
So they have to pay a $20 copay plus the remainder of the visit to you?
So that's what usually happens when you're out of network. But now they have this EOB from their insurance company saying they just owe us $20. Which, as you can imagine, when you're like, no,
Going to
you
cause a
owe us.
crazy miscommunication.
Yeah. And so we, our billing person contacted the insurance company, was like, what are you talking about? You can't tell us what to charge. We're not in network. And they said, oh, we're sorry. Okay. Well, what you need to do is you need to email here. And, we use these Medicare guidelines, but we're not a Medicare clinic, nor are we in network with Medicare. And so they sort of apologize, give you the runaround, tell you to email someone to get things corrected. But to this date, none of these EOBs have ever been corrected. And so, right, it's another tactic where the patient feels like they only have this low copay, but in reality, you need to connect the full out-of-network charge. And then they also tell you, oh, well, it's a clerical printing error. Yeah, it's not true. So just go ahead and collect your full amount. It's like, hey, we need the corrected EOB because, as you can imagine, the patient has something that says they only owe $20 when they owe $300. That's not going to go over well, and it's very confusing for the patient, and that shouldn't be on us to try to explain this piece. So this happened with this smaller insurance company, and fortunately the person using it switched insurances, so we dealt with it for a couple of months. But now much larger health insurance companies have been starting to do this tactic to the point where sometimes they may send a correct EOB out of network appearing EOB, but then other times they're putting language in where they say, code FCO45, the amount charged exceeds reasonable amounts, or under legislative action is not allowed to be charged. So they're throwing this on an out-of-network claim that the patient reads, and then they put, if you have questions about your claim or if amount owed, call this number. In the meantime, when you call the insurance company to say like, hey, we're out of network, they give the same spiel. Oh, we get it. No, you can charge the patient the full amount. No, our bad. And then but they don't send out any corrected explanation of benefits. And so the patient is sitting there thinking they owe $20, and the providers are in the uncomfortable position of saying, no, you owe much more than that because you're out of network. And if we had just given them if they had just paid and we gave a super bill and they submitted it on their own, we wouldn't have had to deal with any of this. So this is making it much harder, again, back onto the patient, causing confusion, and it's a sneaky new tactic that someone thought up. And now I've seen 3 different insurance companies start using this. And yeah, driving me nuts.
Is mental health the only field where so many of the providers, such a significant percentage of the providers, are out of network with the insurance companies?
There's one other field that's higher. I feel like I've certainly referenced this other field. It's the other, come on, Parker, think Hollywood.
Plastic surgery.
There you go.
Sorry, Hollywood.
Yes, but to your point, right? the difference with plastic surgery is that supply and demand are about equal. So even though you're paying potentially a lot, or to go to the best plastic surgeon, you're not. Most people would look. Not all plastic surgery is optional. A lot of it is needed, etc. But mental health care is sort of up there with primary care. We're treating disease states, and
Right.
yeah, for over half of all mental health providers to not accept insurance, the supply does not equal demand. So when the demand is so much greater, it opens the door for cut rate services, and then it's another opportunity. But hey, so many people are used to not having insurance coverage. Let's just see what we can. It's normalized, so let's make it even harder. And for the people who do try to take insurance and push that 50%-ish number, let's make it 75%. People don't use their insurance because, hey, then we don't have to pay for it. And that's how you increase profits.
Yeah, wow. I was just reflecting on, we talk a lot about strategies to negotiate higher rates with the insurance companies. And, I just went to an appointment today. And while I was there, I was thinking, like, would a place like this, treating so many different things, even be able to negotiate with the insurance companies? It's probably not even in their, it's a primary care facility. So I'm like, I imagine they don't. They just take all of their contracts, because if you don't take insurance for primary care, like, people aren't going to go see you, unless you're, I don't know, a celebrity getting exceptional care from, I don't know.
Well, Parker, there are, sorry for not letting you totally finish your thought. There are, though, even in primary care, these concierge practices that have popped up.
That's right.
Which I think
That's right.
most people have heard of at this point. And so it's sort of, hey, keep a disaster health insurance plan if you have a serious hospitalization or cancer, right? But people are otherwise pay $30,000 a year, or I don't know the concierge prices to get. I don't for some things I don't think they're that high, but
right. I wonder if the concierge people are submitting out-of-network claims on behalf of their patients.
That's a good question. I don't know any concierge practice that is doing that. I would say, Parker,
it's not
though,
very concierge of them, but sorry, go on.
I have a lot of friends in pediatrics and internal medicine, and a lot of them do tend to join larger groups that have sort of fought over the years for more reasonable reimbursement. I do think, it's fair to say maybe that's something that could be an advantage for psychiatry, that because our actual billing is simpler than primary care with all the tests and add-ons and other procedures, that we have sort of a streamlined billing process. We do have that opportunity to push directly back on these individual 20 most common CPT codes. And I think it would be, I have a friend who left a hospital practice to take over a primary care, essentially a solo practice for a guy who was retiring, but he is in a physician group that has those rates. Medicare for internal medicine doctors, Medicare tends to pay reasonable-ish also. So if you just sign up for Medicare, you can put together a budget, and I think a lot of those clinics do a percentage above Medicare is what the negotiation would look like with the insurance companies.
Gotcha. Okay, well, those are my kind of rant questions. Did you have anything else you wanted to cover before we wrap up?
I have a whole other saga list that I think we should save for a part 2. And this has to go with fighting for patients to get single case agreements, and sort of can talk about these couple different cases that have been months in the making, and the ridiculousness around the ridiculous around everything resulting from these cases. I will say that after, there is a happy ending potentially at the end of all that, depending on how you look at things. But it really exposes some heartbreaking and maddening, like at least 5 illogical, maddening, unethical, heartbreaking things along the paths, and they are sagas to be shared. And let's do it justice by sort of focusing on that in our next podcast.
Wow. Okay. Stay tuned for that. Okay.
Stay
That
tuned
sounds
for
good.
that. That is spurring. I have two pieces of legislation. I want to get someone to take up the cause with me, and I feel like when you have the individual stories and people who suffered because of from my years of being on this government affairs committee, one thing you learn is that it's great to have an individual face to attach to a story about new legislation or suffering, and that
Right.
it's good both politically. You want bills to get passed, so it's good to be able to put a face to the story, as is known by news reporting and other things, why they always find an individual to talk about within any story. But I'm no marketing expert, but I feel like
well, yeah, look forward to that. And now a brief word from Rai, our AI mental health practice advisor.
This is Rai, your AI mental health practice advisor. Practice owners often ask, what should every clinician set up before seeing their first patient? Before seeing your first patient, set up your administrative systems: intake, scheduling, registration forms, office policies, patient communication, and, if you take insurance, claims submission. Without preparation, patient onboarding becomes inefficient and risk increases immediately. For more practice advice, ask me a question at RipsyTech.com.
I forgot to bring up another ridiculous piece, but I'll add it to next week's podcast. But
Okay.
it's
Sounds
around
good.
it's around lying. It should be illegal to blatantly lie in contract negotiations.
I mean, yes, it's not illegal to lie in a contract negotiation? Mislead
apparently not.
investors or anything like that. That's crazy. Okay. All right. Look forward to that. Well, that's it for this week's episode of the Sit and Stay podcast, brought to you by RipsyTech. If you enjoyed this episode, we'd love a rating or review wherever you're listening. If you want to get in touch, give us an email at sayandstay@ripsytech.com. All right, Don. This was an interesting one. I'll see you next time.
Enfermos tuere, Parker.
Enfermos tuere.
Enfermos tuere.
Yes, which means protect the people. I forget. I already forgot. I mean, sorry. It doesn't mean ars gratia artis. Maybe go see an MGM movie. They'll explain what that means. All right. I'll see you later.
Thanks, Parker.
Bye.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at RipsyTech.com.